Hello and welcome to this evening's webinar. I'm Carla from Fertility Network UK. I'm the England coordinator, and tonight we're joined by guest speaker Dr Jane Stewart, who's a full-time consultant in reproductive medicine at Newcastle Fertility Centre, and has previously been the chair of the British Fertility Society as well. This meeting is being recorded and will be available on our YouTube channel within the next couple of days as well. We will post the link on our website and social media. If you have any questions, pop them into the Q&A box and we'll get through as many as we can at the end. Don't worry, you will be anonymous as we won't read out any names. Everything in the charity we offer is completely free, but if you'd like to donate to help us continue to offer out this kind of support, you can now text to donate. You can make a one-off donation. It's really quick and easy. So if you wanted to donate £5, you text FNUK5 to 70085, or to donate £10, you would text FNUK10 to 70085. But for now, we'll move over to the questions for Jane. Welcome.
Thank you.
Good to have you this evening. So the question, we'll start off with some questions. It would be helpful if you could start by explaining what kind of treatment fertility patients should be able to get on the NHS in the UK.
Okay, so fertility starts with understanding what's going wrong. So it's really important that people can be assessed in primary care, that they can go and have a conversation with their GPs about their fertility concerns, and that if it's appropriate, they can be referred for investigations. And NICE talks about all of those things. After that, treatment will depend on what the problem is and whether it's actually relevant to take people through treatment. Sometimes when we investigate people, actually we find that everything's fine and we can reassure them and they can carry on and try for a bit longer before they have to start thinking about getting into serious, complicated treatment. But from a treatment perspective overall, obviously we often think about assisted conception treatment. We think about IVF and ICSI and all of those processes. Some of them are locally commissioned, some of them are commissioned nationally. There's a variety of ways of getting funding and things for it. But in general terms, NICE would suggest that people should be able to have ovulation induction treatment if they're not ovulating, that they can have ART if they've got another problem, and evidence-based type treatments that are appropriate for their fertility problem. We often think about IVF, and so that question may be a little loaded to say, well, what about IVF? And NICE will say that it is cost effective and therefore appropriate to treat women under the age of 40 with at least 3 cycles of IVF or ICSI with the frozen transfers that go with that. For women over 40, if they have a reasonable expectation of a good chance of success, in other words, they've got a good ovarian reserve and therefore they're likely to at least get eggs and therefore embryos and therefore an opportunity for success up to the age of, well, they say 42, so 42 completed years up to the 43rd birthday, if you like, that 1 cycle would be appropriate in that setting. That's usually applied for people who haven't had prior treatment before, but that's what is suggested that should be offered.
So why doesn't everyone get sorry, I'll start again. So why doesn't everyone get that at the moment? With the postcode lottery, different rules for different nations and different areas of England.
Yeah, and it's exactly that. It's because the funding comes from different places. So unlike some very specialised services, fertility has never been nationally funded, and certainly not in England. There has been a national arrangement set up in Wales and Ireland and Scotland, but in England it remains the responsibilities of the local commissioners, the CCGs, and now the commissioning groups, to commission for fertility treatment. And consequently, when the CCGs were set up, and the PCTs before them and everybody else before that, they set their own priorities for funding, whatever they feel their community needs, and those regulations or rules or commissioning arrangements then are passed on to patients. And so in some areas it's not seen as the same priority as in others. It's not an absolute requirement that they follow NICE guidance, but there are many CCGs, as we know, and you'll see on your site, that don't actually comply with those NICE guidance, although they should. It's their own separate arrangements, and they will say whatever they say, they can't afford it, it's not cost effective, it's not whatever. And so unfortunately, that takes an awful lot of people out of the commissioning. The other thing that happens is that they then set other limits on it, so non-clinical limits, such as the arrangement that if one or other partner has a child already, that's not okay, they won't get commissioning. And that's different in different places as well. They sometimes exclude specific things. They don't always allow for the use of donor gametes, for instance, or, as we've heard very regularly, treatment for same-sex couples or single women. So there's all the separate layers of rules added to it. But the principle of it is it's to do with the commissioners, and in England the commissioning is local, and therefore it's always going to be different from place to place.
Yeah. As a fertility specialist, is it difficult for you when offering people different levels of treatment just because of where they live?
Well, it would be, and it has been in the past. We're very fortunate in the Northeast where I work because our commissioners actually produce a common commissioning document. So our catchment is Cumbria, Northumberland, Newcastle and Tyneside, down to Durham, and that area, all of those commissioners have come together and said this is what our rules are. So in fact, it doesn't matter where you live in our region, there are still restrictions, but in principle everybody has the same. So that helps quite a lot.
And one of the other things that can often find is that treatment's limited in other ways too, such as like you've covered previous children, BMI and smoking and ovarian reserve. Could you explain some of these, please?
Well, I think there's a difference between making a restriction because somebody's been a parent before, or in fact their partner's been a parent before, or their partner has a child somewhere else that they don't really see, but they've actually conceived a child before, which is quite a judgmental thing, isn't it? It doesn't really tell you much about this family and the needs of those families. And I have to say that we live in a society now where there are many arrangements of family, including families that break up and reform and all sorts of things. So to say that just because one partner has a child already means that you can't then, for instance, treat the woman's tubal problem. So if she's got a tubal problem and her partner's got a child he never sees, we're not treating that medically. So I don't think that's really a very fair way of dealing with it. And that's been a long-standing problem across the country pretty much. There are other things. So part of the assessment or the workup for fertility that we've talked about, you go to your GP, you get your assessments and things, is to think about lifestyle. What can you contribute yourself to the process? And part of that then is being fit and well and healthy, and that means thinking about taking your folic acid, having your smears up to date, but also thinking about how you eat, what you eat, your alcohol consumption, smoking, stopping for pregnancy. And BMI is a key one, and it has been a hotly debated thing over time. There is an element of usefulness in having a reasonable BMI, and most centres will have a cut of 30 or 35. NICE says 30, the British Fertility Society upheld that. Certainly what we work with in Newcastle. And the reason for that is in part because it has to do with success rates, but it also has to do with safety, and it also has a lot to do with safety in pregnancy. And if you look at maternal mortality statistics now across the country, very many of those problems have, as part of the problem, as part of the component that led to a maternal death, for instance, being very overweight or being overweight. And so, if we're helping people, and there are lots of people who get pregnant when they're heavy, don't get me wrong, and they might get away with it, and it's absolutely fine. But there's an inherently increased risk of obstetric problems, obstetric intervention, and therefore the complications of it. So if we're trying to help people, we want to start from a place where they're safe to begin with. So there is an argument for BMI. And if we come away from IVF, if you talk about, for instance, ovulation induction for polycystic ovarian syndrome, for women who are heavy, if they can lose some weight, they can correct some of the metabolic problems that are going on, and that makes it easier to treat in a more simple way, and therefore less complicated, less risk of multiple pregnancy, less likely to get into complicated treatment. And so there is an argument for that. And so it's not, therefore, I don't think, very uncommon for CCGs to have built that into their commissioning. But actually, I would apply that to self-funded patients as well, because it's a clinical issue rather than a judgment thing like having a child already.
How quickly do you think the government's women's health strategy is likely to make a difference for those with children from a previous relationship? The strategy says non-clinical reasons for refusing treatment will be ended. And when is that likely to happen?
I wish it was tomorrow. And I'm sure we all do, and I'm sure there's plenty of people here that would like it to be very soon. We've got a great advocate in Dame Leslie Regan, who has been made the representative for that, and I hope that she will continue with the energy that she does everything to push for the whole of the women's agenda that they've put forward. From a fertility point of view, it's a portion of the whole thing. The biggest issue, I think, is that as yet, that apart from making that appointment, I don't think there has been any declaration that there will be funding to support the various initiatives that are there. How's that going to work? So at some point, there needs to be a gathering together of the people that make those kind of decisions, and they need to decide that that's going to happen, and they need to make it happen, and there needs to be the funding go into it to allow it to happen. So I'm afraid it's not going to be tomorrow, but I think it really is a big step in the right direction. Lots of us have been involved in those discussions when they were gathering the evidence, if you like, to try and make those kind of arguments. And I think our job now is to make sure that people don't forget that those points have been well made, and that the pressure stays on.
Yeah, I think you've covered some of this just previously, but I will just ask it. Are there valid clinical reasons to limit treatment for BMI, smoking, and ovarian reserves restrictions?
So we talked about general health and wellbeing, smoking. We talked about the BMI bit, but the ovarian reserve restrictions are valid. I think we're thinking then again about IVF treatment. So ovarian reserve assessment we do commonly for people when they're coming through for any fertility assessment. What's really important to remember is that your ovarian reserve does not affect your natural fertility as long as you're ovulating. So it's not a measure of egg quality. The best measure of egg quality remains woman's age. All right. So for natural fertility, ovarian reserve is not important. But when you start to do artificial things with your ovaries, trying to push them to make extra eggs, and most of us still want to be able to do that in order to get a choice of embryos, to be able to have a good quality embryo to put back and possibly something to freeze. So if you're going to have that response, you need to have some follicles going through the maturation process to allow that stimulation to work. It's not to do with the dose of drugs that we give. If you double up drugs for IVF, you don't get double the number of eggs. It's to do with how many are in the ovaries and then crossing the threshold to make sure that they're stimulated. So if you have a good ovarian reserve, you'll get a good number of eggs. If you've got a poor ovarian reserve, you won't get such a good number. If it's very low, it just won't work. It won't happen. So there has to be some sort of threshold to be able to say to people realistically, this isn't something that you're going to easily be able to do. And if you couple that with age, it starts to get into that area where you might say no, which is why NICE have said if you've got a good ovarian reserve of between 40 and 43, a cycle of treatment. But if the ovarian reserve is not good, then not, because a young person's one egg that makes a nice embryo will give a much higher chance of success than an older woman's one egg that makes a nice embryo. And she's much less likely to get that egg in the first place. So ovarian reserve low ovarian reserve can happen at any age, but it's different if you're older and younger. So there's got to be a judgment at some point about when it becomes a sensible thing to embark on. And so what we'd hope is that with collaboration with people, with patients, that we can have a realistic discussion about that. And there is an absolute clinical argument for saying maybe you don't need to do this to know that it's not going to work, for instance.
If IVF isn't funded locally, should people still be able to have fertility tests on the NHS?
I believe so, yep. And I think I'm not aware, and people can correct me if I'm wrong, but I am not aware that there are any commissioning restrictions that stop people from having investigations. There's nothing wrong with going and having a conversation with your GP because you're worried about your fertility. There's some simple things that can be done in general practice, taking of a good history, the lifestyle things that we've talked about, checking, understanding that you've got a regular cycle and therefore probably ovulating, possibly doing some tests to confirm that, and then undertaking a sperm test. So those things are easily done through primary care, although it isn't always done, but also a referral through to a specialist to talk about what those things mean to finish off that process. The restrictions generally relate to IVF and ART, so donor treatment, IVF, those kind of things. Not so much ovulation induction, actually, the commissioners kind of forget about that as being anything to think about. Perhaps if you use gonadotropins, which are more expensive. But the restrictions mostly relate to treatment. So people should be able to get a good opinion. And I always encourage people to do that, because the last thing you need is to set off and not take that advice or look for that advice and then decide, well, you need IVF and maybe you need this and maybe you need this. Take yourself off to a private centre and end up going down a route that you don't necessarily need to go down. So I think it's hugely valuable for people to get good advice beforehand, in secondary care or in an NHS centre, or to get private advice if they prefer to. But from the point of view of the process and the nice guidance, absolutely, indeed, people should be able to have that opinion and then make up their minds about whether or not they want to go to treatment if that's relevant.
Yeah, and I think you just touched on this. Is there anything people can do if they can't get NHS treatment when nice guidance would suggest they ought to?
Well, I think you join the campaign, really, I suppose, isn't it? Write to people, write to your commissioners. If you think you've got an exceptional case, you could ask your GP to put an independent funding request in. The difficulty with that is that although we all believe we're exceptional, there are many people in a similar situation and they aren't often supported. But if you genuinely have something that makes you different from other arguments, then that's one way of approaching it. And it's, the more IFRs that are put in and turned down, the more annoying it is to the commissioners and the more they need to think about what they're doing. So it isn't a bad thing to request. GPs hopefully reasonably sympathetic to it, and because in primary care fertility patients are kind of spread out, they're not going to have to do millions of them all the time, so if they're interested they would hopefully support that. But the other thing is to write to your MP, write to the commissioners, join the campaigns from FN UK and Fertility Fairness and those kind of things, and just get your voice heard.
And with secondary infertility, what fertility tests could people access on the NHS?
Well, they should be able to access all of them. I mean, just because you've had a pregnancy before, so secondary infertility doesn't necessarily mean you've got a baby, but just because you've had a child before doesn't mean to say there's not a problem. It doesn't make it less anxiety making. People often feel guilty because they're going along and saying, well, I've got a baby already, but actually I really wanted another one. Can I have anything? And they're easily knocked back then because they sort of think they shouldn't have the right to that, and that's not okay. It's just as distressing for people not to be able to complete their families, or can be very distressing. So I think that people should be able to have all of those investigations through the NHS service, and certainly they do in our region. And I think one of the GPs don't always know what their commissioning regulations say, and they think that because somebody's got a child already they have to be private from then on. I think that's probably not the case for most regions. I haven't seen all the commissioning guidance for all of them, to be fair, and I think it is something people forget to scrutinise, but I'm not sure that those restrictions actually hold true.
For people who have to pay for private treatment, it can be very expensive. How can people make sure they get the best price they can?
It is a really tricky one, but I think actually my advice always then is to take advantage of getting that good discussion first before you decide what you're going to do. Because for most people, if they need IVF, which is really what we're talking about again, if they need IVF, then the good quality, straightforward IVF is all that's needed. You don't need a whole lot of other stuff. And one of the worries is what I've said before, is where people haven't had that advice about their issue, think that they need something in particular, and then end up going down this cycle of oh yes, and maybe if I have that as well, that'll just give me a little bit more chance and a little bit more chance. So there's the concept of all the add-ons, which we'll talk about in a minute, but I think the main thing is just to keep in mind that good quality IVF will serve a purpose without adding a lot of extra stuff into it. So for most people, if you've got a tubal factor, for instance, bypassing the fallopian tubes is the main thing. You don't need a whole lot of other stuff to change the lining of the womb or anything else. You just need eggs collected, embryos made, an embryo put into uterus. That should give you a very good chance of success. If there's a sperm factor problem, putting eggs and sperm close together in the lab is a good way of dealing with that. You don't need a whole lot of extra stuff. If you have a particularly difficult sperm problem, then ICSI becomes a relevant thing to do. You don't need ICSI if you don't have that problem. So it's getting the right advice about the right things, about the basic things, that will give you a good chance of success. And After that, not jumping into a whole lot of other stuff that people say, oh, maybe if you just try that, you'll get a little bit extra help, because a lot of the time that's not true.
Yeah, obviously you've just said about additional treatments, but just got a question if we've got anything else to add to it. There are lots of additional treatments available now on top of IVF which patients may be offered. How can people make decisions about what's worth paying for?
So I think you have to listen to the experts that you've taken on and you're trusting. So, that's one thing. Don't be, as seems to be the case when you hear some of the stories, inveigled into it once you've already committed to a cycle of treatment, when somebody then says, after you've had your consultation and you set up your treatment, somebody then says, oh, well, but you could have this if you pay us a little bit more. This might be a different thing. Because if it's not part of your original consultation, or if it's not a standard part of the treatment that they're offering, it may not have great evidence behind it. And a lot of these things don't. So ask about the evidence, but certainly it shouldn't be something that you look at a price list and say, oh, well, if I do that as well, maybe that'll give me an extra percentage point. And because almost certainly that's not the case. Add-ons are add-ons when they're offered without evidence or with little evidence to show benefit, and also then you're paying for it. So if people believe that it's a useful thing to do, it's either very useful for a very specific group of people, in which case if you're in that group, they should have been talking to you about it from the start and why. And if you're not in that group, you don't need it and it won't help you. Or it's something where they believe it helps everybody, in which case it should be part of standard treatment. You shouldn't have to pay extra for it. So that's the way I would think about it. One of the most useful things is to go to the HFEA website. People have criticised their traffic light system, but it does give you at least an idea that there are some warning signs here to ask about these things and be careful about them, because the evidence isn't there, or they're not validated, or they can be expensive and they're often asked for extra. So I think taking good advice to begin with, possibly taking independent advice so you know what you're going for, and then remembering that good quality IVF is good. It doesn't need a whole lot of extra stuff for most people.
Okay. In terms of access, it can be particularly hard for people who need donor eggs or sperm, and many go abroad for this treatment. How difficult is it to get donor eggs or sperm here in the UK?
It's definitely not easy. So, and you can understand that. It's an altruistic thing for people to provide donor gametes, and it's not for everybody. And so it can be difficult to recruit, particularly egg donors, but equally now sperm donors. But the biggest issue at the moment is that during COVID, I think recruitment in most places who were recruiting donors was shelved. We couldn't bring donors into the centres. They didn't want to come in. So certainly we had a big problem with recruitment, and it's going to take us a long time to recoup that gap, really, I suppose. Increasingly, certainly for sperm, we bring sperm in from overseas or from other centres. And Newcastle's not a big metropolis, so we don't have an enormous population to draw donors from, so we bring sperm in from elsewhere. Egg freezing is not as straightforward as people sometimes think, but increasingly egg banks are being generated. So I think there will be more egg bank availability over time in the UK. There are some centres already that bring eggs in from overseas egg banks, I believe. And there are some agencies that deal with recruiting of donors and setting them up. Sound quite nice, very expensive. If you've got the money, well, then go for it if you think that they're going to do for you. But generally speaking, donors are not easy people to recruit.
We've also heard that there's particular difficulties with getting eggs and sperm for some ethnic minority groups. Do you know what the situation is with that, and is there anything that can be done?
I think it's true. I think it's in part a cultural thing, because in some cultures it's just not okay, and that makes it difficult for those people that do need it. And the minority of people that are prepared to come forward as donors, if they do, that's fine, but they'll be picked up quite quickly. So I think I just have to say that that's actually the case. So it is possible to bring your own donors. Sometimes people are able to recruit their own donors, family members sometimes, otherwise friends, people that they know, people that have volunteered because they've heard they've got a problem. Some of the issue around donors is just awareness. So when there's something in the press, they're talking about donors, there's often a little flurry of interest. So if people are prepared to talk about their need for a donor, then sometimes things happen. it's not an easy thing to talk about. It's not an easy thing to put out about yourself, that you need that kind of help. But if you're willing to do that, sometimes things happen. But overall, it's just an awareness thing, and also we're dependent on the goodwill of people, and that's variable. We have little fits and starts of people coming forward.
And will the NHS fund to use an egg donor for IVF rather than using their own eggs due to it being a carrier of a genetic condition?
So genetic problems are a slightly different thing, because there's not always a fertility issue then. So for somebody who's a carrier of a particular condition, one of the options is pre-implantation genetic diagnosis. That's not always the feasible for people, and then gamete donation comes into play. PGD is interesting because it's commissioned nationally. It's commissioned by NHS England, so it doesn't have quite the same rules and restrictions around it as fertility treatment does. But that need for people with genetic problems who can't use PGD, I said PGT is the new thing for it, PGT for diagnosis, for people who can't use that, gamete donation is not included in that national funding, so it's not an alternative from that, so they come back into the fertility sector, and as before, that's very variable. In our region, our commissioners will say that they don't fund gamete donation treatment, but they allow us to use our discretion in using alternative gametes for treating people. So in principle, we can take people through where they're eligible with donor eggs or donor sperm, but they're not always eligible, so it depends on the circumstances for that. But it's not overtly commissioned specifically, the egg donation side of it. It's really tricky, and I think there are lots of regions certainly around England, where it's just not considered a thing.
We know there have been issues for the LGBTQ plus community accessing treatment. With the Women's Health Strategy, it talks about ending that for female couples. Will that happen right away?
Well, it's the same as the issue about other couples being restricted for other reasons. I think it won't happen straight away. I think it's great that it's out there. I think it's great that people are thinking about it. The biggest issue is the inequity of it all, and I think certainly at the moment, given various other pressures and other funding streams, same-sex women looking for treatment, single women looking for treatment, are probably the people that are mostly pushed aside from a funding point of view at the moment, and it isn't fair. So I think it's one of these things that hopefully will come out as a positive from the initiative. But until there's commissioning, until somebody says yes, we will commission that, we won't still be able to do it. So it's got to be made to happen.
We have seen that there can be considerable inequality to access NHS treatment. What would you like to see happen?
I'd like to see that, well, I'd say like the devolved nations, but actually, Scotland's kind of got it right. But then I read yesterday that if you have a cycle of treatment in Scotland and you're eligible, then it might be another 6 months to a year before you get your second cycle. That's not great. So I think really we need to grasp the nettle and say there's not enough funding going into it. It's not an expensive process compared with lots and lots of other medical issues. For young people of the age group who are looking to start their families and need that kind of help, it's one of the commonest reasons for going to primary care, to go into their general practice. So it's a huge thing for that group. But I think people aren't very sympathetic to the idea that young people actually want to start their family, and how distressing it is that it doesn't happen when they think they would like to, and how much more distressing it is when actually you think you would like to have some help, but actually it's not there for you. So it really does need to be funded as per the NICE guidance, without the social bits put to it. When NICE brought out the guidance originally, which was in about 2000 and something, I've forgotten how long ago now, it was revised in 2014, but it came out years before that. There was an opportunity then by the health minister to say what the restrictions would be, if there were going to be any, and they declined to do that. They decided not to in government, which left it then for the commissioners to make up their own rules. And that was a big mistake. It should never have been like that. It should have been properly decided, here's the funding, this is how it is, and then it would have been equitable across the board. And sadly, that didn't happen. There's been a lot of discussion about trying to bring it centrally, trying to get tariffs to make it easier for people to commission, and nobody's really managed to sort it out properly. So it has been a mess really in England for a long, long time. So what I'd like to see happen is equity. I'd like to see equity across all of the nations, but equity, and that we're not making social judgments about it.
I wanted to ask, is egg freezing funded on the NHS, and when might that happen? But also, would it be possible to have it funded for someone who has a condition such as endometriosis?
It's a really good question. So fertility preservation is funded in some situations. Originally, it was mostly, and I'm probably talking about our experience in the Northeast again, but was for people with a cancer diagnosis where they were going to have treatment that was going to damage their fertility. And so we could store sperm, or later we could store eggs or embryos first and then eggs. That was a bit difficult because that meant that if you were having the same sort of drugs for a benign condition, I say benign, but so some kidney problems, some arthritis problems, use similar chemotherapeutic agents that might compromise your fertility, but because they weren't cancer patients, we weren't allowed to do that, or at least in principle the funding wasn't there. So that was a bit mad. It has opened out a bit more recently, in that we certainly now have commissioning for people where there's an expectation that their ovaries aren't going to provide them with eggs for long enough to have an opportunity to conceive. So that might be people, for instance, with metabolic problems who might develop premature ovarian insufficiency, or young women who've got a very strong family history of premature ovarian failure where the risk is they're going to lose their fertility early. So we've got a little bit of leeway there. There has also been a big legal challenge for commissioning for trans people to store gametes prior to their medications being started for their transitioning, and that was a legal thing because they're as a group are protected in law as a protected group, and therefore it was argued that they therefore should have rights to have that. And that allowed us to argue for other people as well. So in fact, it actually helped a bit. So there are some areas where fertility preservation is available on the NHS. It's broader than it was. I'm sure that it's not across the board in all regions either, for the same reasons that we've talked about before. Should it be available for endometriosis? Well, the one thing that it isn't available for is social egg freezing. So people freezing eggs because they're worried they might not meet their partner, which is often the commonest reason for that, or because they're older and the delayed and they're wanting to store eggs in case of further delay. There isn't commissioning for that, and part of the reason is because there's not a risk of premature infertility. And with endometriosis, although there's a likelihood that IVF might be required, the women with endometriosis' ovaries generally are likely to remain good or functional for a long period of time, and the argument would be then that that's not being compromised, and whilst they might need treatment, their ovaries will still be functional for that at whatever stage, and that if they're ending up, I'm sorry, this sounds really awful, but I'm just trying to explain what actually happens in reality, is that if you delay, then you've delayed, and if it's harder then to have treatment, it's no different than having a tube problem and delaying your treatment, or a male factor problem and doing it at a later stage. So there's an argument that if the ovaries aren't touched. However, if there's been a lot of surgery around the ovaries, if it's likely that women are going to lose an ovary, or that they've had big chunks taken out of the ovaries, or are likely to again, then I think you'd put an argument forward that perhaps they should have funding. So it does depend on the situation, but it's not with ovaries and whether or not they're functional, how long they will function for, and whether that's going to be a normal longevity or whether actually there's something that's going to shorten that.
And I assume there would be an age criteria for that, for if it was to be NHS funded.
You have to make a judgment based on ovarian reserve as it is, and age as well. Yes, you're quite right. And in endometriosis, it can be complicated even further because, as I don't know the situation for the person that put the question, but sometimes what you find is that endometriosis sticks your ovaries in peculiar places, which makes it really difficult to get at them as well. So there's other factors that you have to take into account when you're dealing with endometriosis too.
What, if any, NHS support is available for women over 40?
So there should be at least one cycle of treatment if you've got a good ovarian reserve. That's what NICE says. And that's how it is. So, but not in a lot of places, sadly, for the reasons that we've said. That's how it's supposed to be.
Okay. We'll just have a little look at the questions that have come in this evening. Somebody was due to start IVF in February with the NHS and fell pregnant naturally in January, which sadly ended in a miscarriage at 11 weeks. Am I still entitled to IVF on the NHS? I've got a lower AMH and a large family history of early menopause. I'm 36.
Yeah.
Partner has low morphology and a low sperm count as well.
There's clearly plenty of reason to go down that route if you've tried for a decent length of time. Now, I would always think that if you've, it's really rotten to have a pregnancy loss, particularly if you've managed to conceive on your own whilst you were setting everything else up. And I'm really sorry for that, but it shouldn't change your entitlement to IVF if you've had a pregnancy loss. If there was a diagnosis beforehand that meant that you were less likely to conceive and had a fertility diagnosis, then whilst you might want to try for a little bit of time again for a natural pregnancy, you might have just as big a delay the next time. Not most of our patients, most of our couples coming through trying for a pregnancy don't have no chance. And sometimes, luckily, it happens for them. Sometimes, unluckily, it happens for them and then they miscarry, but they still have a fertility issue. And so there should be no change in your entitlement. It's whether you want to pick that up straight away or whether you want to wait. Now, if you've got a male factor problem, your chances ongoing are probably still very limited. And if your AMH is lowish, you don't want to leave it for too long. So I would pick up with them as quickly as you could, and you should still be able to have that cycle.
And is there a period of time after sadly having a miscarriage that you would then have to wait to be able to have NHS funded treatment?
Shouldn't be any restrictions. There's no have to about it. So from the point of view of being pregnant, the best thing is at least to have had a normal period, because you can date a pregnancy then. So if you have a pregnancy loss and you're trying to decide whether to get pregnant again, people do sometimes conceive straight away afterwards. I'm just talking about in general terms to do with miscarriage at the moment. They do sometimes conceive straight away afterwards, but then it's difficult to know when the pregnancy actually started because you don't know when you ovulated. And so if things aren't looking good, it's difficult to date it, and all that kind of thing gets a bit complicated. So if you had a normal period, and normal periods can be 6 or 8 weeks after a pregnancy loss, then you know how to date your next pregnancy, and then that helps from the point of view of ongoing. But so there's no restriction about when you should try and be pregnant after having a pregnancy loss. If everything's settled down, if you've had a normal period, no reason to delay things. And therefore, from a funding point of view, there shouldn't be any reason to delay it. And the only thing is that sometimes, particularly for young couples, where perhaps if you've got an unexplained problem and you're starting down the route of treatment, maybe at the 2-year mark, and you've got good ovarian reserve and your chances aren't going to change hugely over a short period of time, it's probably then, if you've had a natural pregnancy, emotionally, if nothing else, worthwhile just maybe trying for a little bit longer before you pick up on that treatment again. But there's no rules about that. So if people just want to get on with it, if they've already got a diagnosis of a fertility problem, why wait? Come back to the IVF if they want to. So I wouldn't lay down any particular rules, although I might encourage people to think about what they wanted to do.
I have no fallopian tubes because of ectopic pregnancies, but my partner has a child from a previous relationship, and therefore my GP would never refer me for NHS funding for IVF. It's really frustrating, as I'll never fall pregnant naturally. Can I appeal this? I've had 3 rounds of IVF self-funded, all unsuccessful. Would like to think I could keep going, but financially we cannot.
Yeah, that's a really difficult thing, and it's exactly the point I was making before, Sarah. So the point about funding and saying that there's no funding if one member of the couple has a child already means that we are sometimes not, and this is exactly that situation, treating your medical problem. You've got no tubes. That's nothing to do with the fact that your partner has a child already. You can't get pregnant on your own, and I really, really believe that should be a commission treatment. You could appeal it. you take yourself off GTP, put an IFR in. The difficulty now, though, is that if you've had cycles of treatment unsuccessfully, NICE guidance is very much based on risks and chances and cost effectiveness. And one of the things that comes up then is that if you've had, or the way that commissioners often apply this then, is that if you then have had cycles of treatment already, however they were funded, wherever they were done, then you've already passed a threshold of that cost effectiveness, if you like, and therefore your fourth and your fifth cycles are less likely overall to give you a pregnancy, although they still might, and you might still have a very good chance of success. It does begin to plateau out, and they would argue that if you've had 3 cycles elsewhere, you're not then eligible for NHS funding. So even people who, for instance, if your partner didn't have a child already, if you'd had treatment elsewhere, then, and we're in a situation where 3 cycles were available, if you'd had 2 cycles already, you would only get 1 NHS commission cycle, for instance, because commissioners apply it in that way to do with the cost effectiveness.
What are the circumstances where a donor egg funding, NHS funding, could be considered in the North East? They can't have PGD due to low ovarian reserve and have other issues such as a genetic carrier.
Okay, referral, and if the other criteria are met, then that may well be okay. So it's the age limits, so 40, 43 would decide cycles, and then if you don't already have a child, then either of you, then that would put you in the commissioning route for ART, and in our practice that would allow us to take you through the NHS process through egg donation. However, you also need to be aware that there's a significant wait for eggs, as I've suggested already, and I've no idea how long our waiting list is at the moment because it's been extended by COVID, and it was previously a couple of years minimum. But if you have your own donor, that changes things. So I would suggest that if you're in our region, that you ask for a referral from your GP or the geneticist, and we can talk about it.
Now, we've touched on this, but do you think the new women's health strategy is likely to improve access to treatment?
I do hope so. As I've said before, I can't tell anybody when that's likely to happen, but I think, as I say, we've got a really good advocate in Dame Leslie Regan. She has the backing of all of the people with interest, the FNUK, to Fairness, the BFS, all of the people that have been trying to make things move, campaigning previously. So I think with that sort of build up of pressure, I hope, and it written into that initiative, she's an energetic woman. I don't think it's all down to her, but I think she can make these things move. So I would hope that with a bit of time, we will get that happen. But I'm not sure it's going to be imminent.
You already have a child through IVF. Can a second be funded via the NHS?
I'm not aware of any commissioners doing that, I'm afraid. So hopefully not.
What do private patients receive that NHS patients don't receive?
In our practice, not, because our patients are self-funded. They come through, they are managed in the same way as our NHS patients because we believe we give them all the same good service. They just pay the trust for their treatment rather than anything else. If you want a fancy place with nice sofas and people who are perhaps a little bit more, I don't know, it's like going to some of the private hospitals to have your hip done. You might get a little bit more creature comforts. But in principle, you shouldn't really be able to get much more. Now, the only thing otherwise is discussion around these add-ons and the freedom of adding different things in if you chose to. So I would argue that if those things were worth having, we could make sure that they work through the NHS. So if I had a treatment that I really wanted to do, we would process it through our trust, and we would have a decision about whether or not it was a worthwhile thing to do. And if we made the argument that we thought it was, then we would be able to use it. So I genuinely don't think that you should or could get anything better through the private sector if it's done properly. You can certainly get more, but you don't necessarily need it all.
Once your application for NHS funding for IVF has been submitted, how long generally does it take to find out if the application's been approved?
So I think That again will depend on commissioners, because if we talk about an independent funding request, that the commissioners will meet once every 2 or 3 months and they'll make decisions on IFRs. We don't have to we don't have to apply for individuals to have treatment. We don't have to apply to the commissioners for it, because they have this joint commissioning document which allows us to apply their rules to, and so we'll get a referral and it's appropriate to treat people, then we treat them. So we don't have to apply for them. So I think it depends a little bit on the region and how they set that up. I think for most people, if there's specific commissioning written down, they shouldn't really need to apply on an individual basis.
Are there any tests or procedures on the NHS we should ask for to ensure we have the highest chance of success? Got a history of PCOS and sadly family history of miscarriages, but a good ovarian AMH reserve, with the male factor issues as well.
So women, so from the point of view of diagnosis, understanding that's good. So you already know that it's a male factor problem. You already know you've got polycystic ovarian syndrome. So there aren't any more tests to make those diagnoses, really. I forgot what the family history was. That was PCOS as well, was it?
PCOS and sadly history of miscarriages.
So if you have a series of pregnancy losses, then there are some clear guidance from the college, our college, the Royal College of Obstetricians and Gynecologists, about things that are worthwhile testing for. And it's like other things, because there's so much uncertainty in early embryo development, implantation, early pregnancy, fertility, endometrial function, because it's still very much research areas. There's an awful lot written and said that actually we don't know. So there are some clear guidance about things that we know are useful to do. So for instance, if people have had a series of miscarriages, one of the things that we want to make sure is that they don't have so-called antiphospholipid syndrome. But there's no great evidence looking for all of the clotting disorders is worthwhile. It's a very specific one. There's specific treatment for it if it's detected, but it's diagnosed based on risk. So if you test after a single loss and you get a positive result, it may not actually be an issue. If you screen everybody who's never been pregnant, you will pick up people where it's never going to be an issue. So you have to be careful about how you do those tests and when you do them. So family history is interesting. If your fertility problem relates to polycystic ovarian syndrome and a male factor problem, it's unlikely that there's anything linking your family history of miscarriage to your fertility problem, because there's two things there already. Why would you look for a third pathology? But for people who have unexplained losses and family history of fertility issues or miscarriages or babies with problems, then sometimes it's worthwhile looking for some of the sort of chromosomal things that go on. So there are some tests that you should have. You need to make the diagnosis of PCOS. You've got that already. You need to have a sperm test to understand about the male factor thing. Depending on the treatment that you might be offered, it would be relevant at some point to look at your fallopian tubes, not necessarily before you have any treatment if you've never had an opportunity to be pregnant, but certainly if you hadn't conceived easily, or if you had a history of a problem that might suggest it. Miscarriages are harder though, because most of the time miscarriages are probably isolated events, not linked. So investigating them is tricky. It's not always very fruitful. It's often left down as unexplained in the same way as we have unexplained subfertility. But if you're under 35 and you've had 3 pregnancy losses, early pregnancy losses, and negative tests of the things that are relevant to do, then your ongoing chance of a successful next pregnancy is still probably about 75 to 80%. So it's not that much different. So most of the time, we can reassure people when we don't know what's going on with their miscarriages. So it sounds like you've had the things that you need to have done. It's more thinking then about setting yourself up in a good place for treatment and getting the right treatment. And if you need ovulation induction, that might be offered, but it would depend on how problematic the sperm is, in which case you might actually move more towards IVF, but that holds different problems. So it's getting that balance right. So good advice is what you need with all the facts in front of them.
I'm 42 years old and had 3 miscarriages. I've had all the tests, and apart from low AMH, given that I'm coming up to the 43rd year birthday next February, how long does an IVF normally take with the NHS? And would you try any further natural conceptions, or do you, or don't, sorry, or don't do anything and wait for NHS IVF?
So it's a really difficult place to be. 42, when you're thinking about thresholds and things, you've had losses. So I don't know everything, and these are getting to be very personal kind of questions. So forgive me if it doesn't quite fit with what you're expecting. But if I can just say some general things. So if you have been conceiving in your 40s, you probably don't have a fertility problem. If you've had 3 losses over the last 2 or 3 years, you're not having a problem conceiving. You don't need IVF. And don't let anybody take you down that route, because that's not going to help. It won't protect you from the miscarriage risk. If you're conceiving, then the easiest and safest way of getting pregnant is to conceive again. For women in their 40s, though, a significant proportion of them won't get pregnant even with normal fertility, because as we get older, our egg quality declines and there are fewer eggs available that are likely to make a successful pregnancy. So eventually we run out of time. For women in their 40s, because of the egg quality, the risk of miscarriage increases, because those eggs are much more likely to have something either subtly genetic or chromosomally that isn't going to allow that conceptus or that egg to make conceptus to make a successful pregnancy. And so you're in a really difficult place, because if fertility is not an issue, we can't improve your chance of getting pregnant. IVF doesn't do that. It doesn't make people pregnant quicker or more easily if they've got natural conception chances, because your cumulative chance month on month on month is almost certainly better than anything that we can offer through IVF. And I would reinforce that by saying that if you've got a low AMH, a low ovarian reserve, then that's in keeping with your age. It's not a pathology, it's just what happens. It doesn't mean that you're about to be menopausal. It just means that you've got a low AMH, but that means it would be tricky to treat. And if your AMH is low, if it's below about 5.4 picomoles per litre, then actually you'd probably be precluded from treatment in your 40s as an NHS patient, because of that discussion that I had before. Commissioning is only available for women who've got a good AMH, but you might not need it. So it is a question probably of taking your chances. And that's really hard, because you've got to have confidence in that and be aware that there's a significant possibility, of course, that you might get there. There's also a possibility that you might not. You might have another loss, or you may not get pregnant again. But if you're conceiving in your 40s, then that's good news to a degree. And it also means that you've still got a decent chance of having a successful next pregnancy. So I think you have to hang in there, and I'm sorry, because that's not necessarily what you hope to hear.
Are there NHS trusts that would accept a private self-referral? And if so, is there a way of finding a list of them nationally, so we don't have to rely on a non-NHS fertility clinic?
So the HFEA lists all of the licensed centres in the UK. You can usually work out which ones are NHS centres embedded in NHS trusts, like ours, for instance. So there are lots of private centres now who do NHS cycles of treatment. They're commissioned by the commissioners to undertake NHS treatment. But if you were looking specifically for an NHS centre that runs self-funded patients, it's the other way around, I suppose. And you should probably be able to identify those out of the HFEA website, I think. I've forgotten what the rest of the question was. That was one about identifying them. And do they take self-funded patients? Yes. Was that the rest?
Yes, it was. Yeah.
Well, certainly we do. The question was self-referred. We always ask for a GP referral, because you get the background information, and sometimes with a GP referral we might write back and say, well, do you know, have you thought about this, or actually have you do they realise? So I try not to have people come through paying for consultations, for instance, if I know that ultimately or paying for all the stuff, if I know ultimately we're not going to be able to treat them. So if there's already enough information for that, I would write back and say, look, can you have this discussion? Happy to see them, or if they're referred through and actually what we need is to investigate things first, then we'll do the investigations first, and then we'll think about whether or not it's relevant to treat. So people self-referring don't always, we get emails and it says, what do you charge for ICSI? And I've got no idea if they need ICSI. They might not need it. I want the information first so that I can have a conversation, so that we can talk together about what's the best thing. Telling them how much we charge for ICSI doesn't help them to make a decision about whether they should see us.
Yeah. Do you know if or when the NHS might be looking to review the funding for areas. I'm in an area that currently doesn't offer treatment, and that's been the case since 2014.
Yeah, it's really frustrating, isn't it? It should be under constant review. The commissioning at the moment, of course, as I said, we're all in sort of bit in limbo with the commissioners, so I don't think there'll be much commissioning changes going on in the very near future. However, the initiative that we've talked about, the Women's Health Initiative, is hoping to drive some change, and I think we just all have to support that and try and make it happen. But yeah, it isn't a click of a switch and somebody in NHS England says, oh, hang on a second, let's just do this properly now. I wish they would, but I can't see it happening straight away. And I think there will still be an element of autonomy for commissioners in England compared with the way they've done it in Scotland and Wales and Ireland. In Ireland, there's a single cycle. It's not great, but it's there at least, and it's all kind of equitable. Wales, I think they're on 2. Scotland have done a good thing because they've made it a national programme. And I think from an equity point of view, that's good, but it's not sorted yet because they still have big waiting times for treatment. So there's difficulties either way.
And I think the last question we have is, with IVF funding in the areas that are entitled to 3 rounds with the NHS, are you still entitled to further rounds if the first IVF cycle is successful, but sadly results in a pregnancy loss?
I would hope so. I think the thing that the exclusions are, they won't fund for a second child, but the pregnancy loss actually, however distressing and frustrating, actually tells us that you can implant a pregnancy, and in many ways puts you in a better position for subsequent cycles and your ongoing prognosis than if you hadn't had that. So to penalise people for that would be a shame. So yes, you should be eligible for the rest of your cycles. You still only get 3, I suspect. I don't think anybody would offer a 4th one because you'd had a loss in the first one, but it shouldn't prevent you from having your subsequent cycles, or indeed the frozen transfers that go with that. So sometimes if you've had a loss, then you might get you might have some frozen embryos to use first before you move on to the other cycles. So yes is the answer, or no is the answer rather. That shouldn't penalise you.
Thank you. And we want to thank Dr Jane Stewart for this evening, answering all the many questions we've had in, and I hope you've all found it very helpful. And we want to thank the audience for joining. And also, if you want to watch the recording back, you can find that on our YouTube channel in the next couple of days, and we'll post a link on our website and our social media as well. And then also, if you feel like you need further support, don't forget the charity offer free support services if you need some help and advice. And also, we just to remind you, obviously we are a charity, and we do have the text to donate option that we mentioned earlier this evening. Thank you very much and have a good evening.
Thank you. Good evening.
Thank you.